indirect and along with direct functional techniques. So let's practice that a little bit. Indirect means away from the stiffness, away from the symptom. All right, so who's got any kind of a symptom of boo-boo you can put your fingers on? Anybody? All right, so now you got an awareness of the spot, and what you're going to do is slowly move it so that it's less intense. Or you can just move the tissue so that you're moving it into more ease. So the direct, indirect stuff is an osteopathic kind of foundation approach. And who knows where they learned it from. You know, nothing is original. But Dr. Chadow, my mentor, taught, always try indirect first. Don't always, you know, if something is twisted, kind of twist it a little bit more. Follow that pattern. Take it the way it wants to go. Or move it away from the symptom. Move it into ease. Move it into where it's soft. And then, once that, you know, they get some relief there, then you start to combine it with indirect, and then you start moving it to the symptom. So you move in and out. You move where it's easy, and then you start to move it where the symptom starts to show. So if I was playing around with the idea of the elbow here, let's say I had a restricted movement right in there like that. I would take it into ease. It wants to go that way, but when I try to bring it out, now it stiffens. So indirect, direct, you know, into the lesion, direct, into the symptom, direct, away from it, indirect. If I had a scar and I was palpating the scar, and I would get my hands on it here and I would slide the tissue and I'd go, okay, it moves up really good, indirect. Moves down, sticky, direct. So slides that way, slides more that way though. My biggest ease is like that. How about if I just held that there and a person move a little bit, or not, you know, and then come back and check again. You'd be surprised how much that will accomplish.
So now how does that correlate or differ at all related to positional release and strain, counter strain?
Those strain and counter strain, positional release are indirect methods. You're going away from the symptom. And then Dr. Chadow would say, do that in the acute phase of anything. And then you can start to move between indirect, direct, and then you can start to, if you want to, move into the stiffness. You know, you can start with some more, you know, like this, if there is a scar right here, I might start with the indirect and hold, and then I might, in a week, go indirect, direct, you know, and see how it responds. And then I might add some movement in there that gets some elongation of those tissues. And then I might lift it up, you know, and hold it at bind. That's direct, you know, but I might finish it up. So you move back and forth with these things all the time. But the positional release, the strain, counter strain, is always moving in away from the lesion. Away from the lesion and holding it there. And massage therapists and physical therapists too they see somebody that's twisted, they got an internal rotation at the shoulder, and their main focus is, okay, let's stretch it out of that. But if you're going to follow this indirect thing, you you would take it, it's turned like that already, you'd turn it more.
Exaggeration of the distortion.
Yep, exaggerate the distortion, hold it there, rock it, shake it, whatever. And then either the person can actively start to twist out of it, or you can assist with them on that. But the tendency, somebody's like this, you immediately start to stretch them out. And you might want to rethink that strategy. All right. Circulation support and lymphatic drainage, you can't not do that. You know, you change the shape of the tissue, you mess with it a little bit, and you are going to, you know, squeeze the capillaries and squish fluid around and move the lymphatic system. And right now in the massage world, we're hyper fixated on the lymphatic drain, or I'm a lymphologist, or I mean, it's, if somebody has pathological lymphedema or lipodema, which is a fat accumulation with it, they have a high exposure to infection and skin changes and all that kind of stuff, and they should be being treated by a medical professional that has additional focus on complex decompressive therapy, which includes a little bit of lymphatic focus. So when we start to think about circulation or lymphatics, it's about mimic normal. So how does the lymphatic system move on its own? Well, it's a pump system, and as you're walking around, you're moving your lymphatics just fine. If you've had an injury, you might get some localized swelling, or swelling within an area, because it acts as a cast. It stabilizes the area, along with supporting a normal inflammatory and healing process. If somebody has had a surgery, this happens a lot with cosmetic surgery these days. If somebody has had that, then you know, you can do some general fluid management in the area, but not right away. Not necessarily right away. It's too much. If there's an incision, there's too much problem with the chance of an infection. And so now we got people that are squeezing fluid out of incisions and doing all sorts of crazy things. Anybody run into this crazy nonsense lymphatic? Oh my God. It's really gotten over the top. I saw you shake your head a little bit. Have you encountered it with the lymphatics?
Were you looking at me?
No.
Sorry.
All right, so this is all about, do we need to do anything? Okay. So this is all about understand normal function. It's the same with breathing. Understand normal function and mimic it. Connective tissue applications are about sliding, making something a little bit more pliable and support the sliding of the layers. So, see, this slides. Nice. If I bunch this up, now it doesn't. So, it's like having a wedgie. You have to decompress your wedgie, right? You have to. All right, so suction cup, no. But the methods are about lifting and pulling and drag, and you do a lot of direct work here. You work at bind, you work where the tissue wants to stop. And that's got a million different names to it. With the trigger point treatment, you're trying to find a spot that mimics the symptom. Nobody knows for sure what a trigger point is, but there are spots when you press on it, it will mimic the system. You've all had that. Oh, yep, that's it. That's the spot right there. Now, it could be because there's some shortening of the tissue and you're compressing a nerve. It could be that there's some impaired circulation in there and the tissue fluid's gotten a little acidic or whatever. The point is that you press on a more narrow spot and you recreate the symptom. If you press on a spot and it doesn't recreate the symptom, but the person says, but it hurts, so it must be something, it's not. These spots tend to occur where there's a neurovascular bundle. And anytime you press on a nerve, it's going to hurt. It's going to have a sensation to it. So your gauge is always, does it recreate the symptom? Once you've got a symptom, then you can go right up here and take a look at your indirect. I got a symptom. Can I move it? Can I move the tissue? Can I move the joint so that it feels better? You know, can I alleviate the sensation? You know, or do I want to just push on it, inhibitory pressure, and have them move the jointed area? You know, so a trigger point is a pathology of some sort. It's a condition, it's not a method. So the treatment is a method, and the treatment on these things is indirect fluid support, direct stretching, hot and cold. You can do a lot of different things to those. Yes, Logan?
I've heard a lot of people, clients specifically, mix trigger point and knots
Knots.
together.
You would.
Yeah.
Trigger points over the years have been classified as palpating a nodule, you know, and various theories there about that. Personally, I think it's a little fibrosis, where there's been an area of inflammation for some reason, and it's the healing process, the tissue's got a little stiff. And then that stiffness impedes the sliding and might press on one of these neurovascular bundles. But I don't know that for sure, that's just my opinion.
But then further, if there's some rigidity, and they'll talk about things becoming stagnated.
Yeah, stay.
But because of the tissue being less mobile,
Yeah,
then fluid conductivity, well, also maybe there is an acidity element from
Yep.
like the fluid elements around a area that has become inflamed and is less mobile.
most of the knots that people say are muscle layering. Do you remember when we were back here and I pointed out all the different layers? So if I always have to massage through the skin, right? So if I'm massaging through the skin here in upper trapezius, and then I go down a little deeper, then I get into the trapezius here. But I feel a lump. I'm probably feeling the levator scapula that's underneath. So if I go over to the other side and I feel the same knot or lump or bump or whatever, it's structural. You know, and if I press on it hard enough, it's going to hurt, right? So a lot of, you know, we're not totally smooth. We got, you know, a lot of different structural layers. And so a lot of the time, that's what it is that you're just feeling structure. Not always, though. You know, so there is a tendency for the bulk of the upper trapezius to get these fibrous knots or something in it, and there's not an underlying structure. But most people, when they feel the knot, since you asked the question, it's usually up in here. And that's very commonly just tissue layering. You know, there's another structure underneath it.
But they feel something before you're even touching them, because they'll say, oh my God, I got knots back here. And the only way they know it is because they're feeling pain.
Yeah, so it's not a knot, it's something, But what, you know, if you think of a balled up, wadded up thing, It's just that terminology problem we've got. And that is a generalized term in the public, and so you know, you gotta kinda deal with it. But if it's a muscle layered thing that's changing the you know, it's like you're going over a speed bump and you try to flatten that out, you're gonna hurt them. You know, so I think there needs to be a little education around. I believe that you're feeling something there. We just got to make sure it is a normal structure underneath that palpates like a knot.
Well, like you said before, attachments for like definitely between the shoulder blades, there's two attachments that people want to grind out, but they're attachments.
They're attachments, that's right.
The levator scap attachment is the one that, like, everybody will always perceive as a knot. It is sensitive, right? So that's just where it attaches in that superior angle of the scapula, that classic one. You're always gonna find something ropey there that will have a sensitivity to it. So people will certainly call that a knot, but that would be the case where it's normal anatomy. It's also gonna be normal based on just nature, how we tend to position ourselves for that to get a little hypertonic and tight. Versus finding a particular part of the tissue that has a very distinguished difference in its consistency, right? That you feel it, and you're going along, the muscle tissue feels uniform, and there's a part of it that is thicker and denser, right? Then the question is, does it elicit the symptom?
Yes.
And more specifically, does it elicit a system that causes a referred sensation? Then you're getting more of what we could call a trigger point, as opposed to, as ideally, rather than calling it knots, we would just call the ones that don't necessarily create a specific symptom tender points. And maybe they do need to be addressed because it's just something that's sitting there and the person hasn't perceived it symptomatically. Maybe you're catching it before it's a problem yet, but if it perpetuated, maybe it would continue. And then it can be that strands of muscle, it could be a region of that, it could be more connective tissue based, but then there's also just somebody has exercised a lot, has a lot of tone, and certain parts of a muscle or a muscle as a whole feels particularly bandy, right? So the quads with the athletes, you go over something and it just feels like you go with that, but it's one big speed bump. It's not just one tiny part of it, right? So that's probably the whole muscle or a bigger part of the muscle being hypertonic and the muscle fibers being just from here to here and maybe more like that. And maybe, if as I perceive it, maybe there's a tendency for these to kind of curl in on themselves. Then when that starts to happen, or if there's a connective tissue element that starts to encapsulate that, then you're getting a sense of more of a ball, a knot, or you're getting just this, which feels like a big bandy speed bump. But people are gonna say knots and whatever.
Yeah.
And, but then maybe you can come up with a way to say it, because if you ask, what's a knot, or what is that? And it's like, well, some hypertonic tissue and maybe some thickened down connective tissue. Now you sound smart and you're done.
And you want to know the history. If somebody has had a situation where they injured a spot, it could have healed a little short, a little more dense in there, especially if they held it short while it was healing. I mentioned that I held my arm in here. And we can potentially over time, I treat it as a scar that I can't see. And then I go back up with the decompression, some of the direct and indirect, and some of that kind of stuff. And people do have, if they've taken a blow, they got hit with something, or a compression injury or something like that, that also has a capillary leakage, you know, and it can get it like a bruise. If you got a bruise, there's been blood into the spaces around the cells, the interstitial spaces. Blood is a coagulant, and if the lymphatic system doesn't uptake it, you can end up with a dried out little blood ball, you know, that mats tissue together. So you got to also look at the history with stuff like that. If somebody's got a repetitive movement that they do over and over and over, they can get a friction which is an inflammatory response, and then two structures that should slide over themselves will adhere and start to function as one. So, but it is, you hear it all the time. I've got a knot, can you get this, can you massage these knots out? What you gotta be careful of with the clients on that is that you don't injure them trying to get rid of something that should be there. And I've done that. Before I understood this idea of tissue layers and stuff, I routinely tried to massage away the levator scapula attachment. And, it's supposed to be there. So, specific releases, there's nothing fancy here. It's almost always either a position of release, finding the spot, trying to move into direct, indirect, inhibitory pressure plus movement, which applies a little bit of a friction in there. The issue is they're hard to get to. These are structures that have a lot of other stuff around them, or they're right next to a nerve or something. So the one that we're going to work with today, and we're going to work around the clavicle, is subscapularis. I mean, how do you get to this stuff in here without causing a tremendous amount of agony? How do you bounce, between this group of muscles and this group of muscles? So that's where these specific releases come in. So. Did I do good?
That's beautiful.
Oh, thanks.